Welcome to The Explainer. Today we're mapping out the physical mechanics and management of 5 really common pediatric skin conditions, right here on our virtual whiteboard. We're going to look closely at the most current clinical guidelines so we can understand not just what these conditions look like, but the actual underlying mechanisms driving them.
Here's our roadmap for this explainer. First, the Pediatric Skin Foundation. Then, contact and diaper dermatitis. After that, we'll hit seborrheic and atopic dermatitis, followed by exanthematous drug eruptions. And finally, a rapid-fire condition comparison to lock it all in.
Section 1, the Pediatric Skin Foundation. Okay, let's jump right into this by understanding why a kid's skin needs entirely different, way gentler care compared to adult skin. Think of the epidermis as a shield. Well, pediatric skin, especially in infants and young kids, has a much thinner shield, and this creates a highly vulnerable two-way street. On one hand, outside irritants like harsh soaps, fragrances, or even just medical tape can penetrate way too easily, which leads to rapid inflammation. But on the other hand, because that barrier is immature, vital fluids escape from the body much too fast. This is a process known as insensible fluid loss. So keeping that in mind, pretty much every single intervention we talk about today is built around protecting and repairing this incredibly fragile barrier.
Section 2, contact and diaper dermatitis. Let's look at what actually happens when that vulnerable barrier comes into direct physical contact with outside irritants.
Contact dermatitis is exactly what it sounds like. It's an inflammatory, hypersensitive reaction that happens when the skin literally touches a chemical, a harsh soap, or plant allergen. Clinically, you're going to see red bumps that can form into moist, weeping blisters, along with intense pruritus or, itching. And notice the location. It pops up exactly at the site of contact. Since it's an external trigger, our very first action is simple but absolutely crucial. Identify and remove that offending agent. Probably the most notorious culprit of allergic contact dermatitis is poison ivy. The specific trigger here is urushiol. That's the oil found inside the plant. So the absolute key when dealing with urushiol is immediate mechanical decontamination. And remember, direct contact with the plant isn't even necessary. That oil can transfer from pet fur, toys, or clothing right back onto the skin. You want to flush the exposed skin immediately with cold running water. Why cold? Because hot water actually opens the pores and increases absorption, and we definitely don't want that. Next, remove and wash any contaminated clothing in hot water with detergent to destroy the oil. Then follow up with calamine lotion or colloidal oatmeal baths and, if prescribed, antihistamines to just help the poor kids sleep through the itch.
Okay, I need to make a high-stakes pivot right here. While a poison ivy rash on the arm is super uncomfortable, it's generally manageable. But you must never, ever burn poison ivy, oak, or sumac. When these plants are burned, that urushiol oil actually becomes aerosolized in the smoke. Inhaling that smoke creates a severe, life-threatening airway compromise. The mucous membranes in the respiratory tract suffer an intense hypersensitivity reaction and swell up rapidly. This goes way beyond routine dermatitis management. It requires urgent, immediate escalation and airway support.
Shifting gears to diaper dermatitis. This is essentially a physical breakdown of the skin from prolonged moisture, friction, and chemical irritation from urine and stool. Because urine increases the local pH, it actively eats away at that already thin pediatric skin barrier. It typically shows up as scattered to extensive glistening erythema, basically shiny redness, right in the diaper area. We manage this with a dual approach. We decrease the exposure by keeping the area totally dry with frequent diaper changes, and we physically block the irritants by slathering on a thick layer of a zinc oxide barrier cream.
Section 3, seborrheic and atopic dermatitis. Now, let's explore 2 conditions that behave a little differently. These aren't just reactions to a temporary outside chemical. First up is seborrheic dermatitis, which you've probably heard called cradle cap. Now, while it looks super alarming to a new parent, and you always have to reassure them they didn't do anything wrong, it's actually a self-limiting condition of unknown etiology that peaks in infancy. It presents as thick, adherent, yellow, scaly patches, usually right on the scalp. The absolute best nursing action here? Patience and gentle care. We tell parents to apply petrolatum or mineral oil to the scalp, let it sit to deeply soften those stubborn scales, and then use a fine-tooth comb to gently lift them away. Never aggressively scrub or pick at the dry scales, because that will just damage the skin.
Next, we come to atopic dermatitis, frequently referred to as eczema. The core mechanics of this condition are truly fascinating. It's not just a temporary rash. It is a chronic dysfunction of the epidermal layer itself. The skin's barrier is fundamentally impaired, which leads to a constant release of inflammatory cytokines. It's also highly associated with a family history of allergies, which is a genetic predisposition known as atopy. Because the barrier is broken, it literally cannot hold on to moisture, leading to severe, chronic dryness and intense pruritus.
And this sets up a brutal, self-perpetuating loop known as the itch-scratch cycle. It starts with that dry, inflamed skin barrier. That dryness causes intense, maddening itching. Naturally, the child scratches the itch, but that scratching physically destroys whatever is actually left of the epidermal barrier, driving even more inflammation and leaving the door wide open for secondary bacterial infections. The inflammation from the damage causes more dryness, more itching, and the cycle just repeats, getting worse every single time.
So, to physically break that loop, we rely on a highly specific daily routine designed to restore hydration and minimize irritation. First, a quick tepid bath, less than 10 minutes. Avoid hot water entirely, because it just dries the skin out even more. Second, gently pat the skin dry. Do not rub. Rubbing acts like sandpaper on a compromised barrier. Third, immediately apply any prescribed topical medications to the affected areas. Fourth, and honestly, this is the most crucial step, apply a thick emollient or moisturizer over the entire body while the skin is still slightly damp. This locks that bath hydration in. Finally, dress the child in soft, breathable cotton clothing to prevent overheating and physical friction.
Section 4. Exanthematous drug eruptions. Let's step away from external triggers and barrier dysfunctions for a minute and look at a systemic reaction.
So unlike contact dermatitis, where a physical substance actually touches the skin, an exanthematous drug eruption is an internal, cell-mediated hypersensitivity to a systemic medication. Common triggers here are antibiotics, like amoxicillin or cephalosporins, as well as anticonvulsants. It typically presents as a maculopapular rash. That basically means flat red spots and raised red bumps that look a whole lot like measles or rubella. It usually starts right on the torso and proximal body areas before spreading outward.
And the timeline here is literally everything. It entirely dictates how we investigate the cause. If a child is taking a medication for the very first time, their immune system has to go through a sensitization phase. That means the rash won't actually erupt until 7 to 10 days after starting the medication. Heck, it might even happen after they've totally finished the prescription. However, if this is a repeat exposure in an already sensitized child, the immune system remembers. The elicitation phase kicks in rapidly, causing a rash to erupt in just 1 to 3 days. Understanding this timeline is absolutely essential for identifying the correct culprit medication.
Section 5. Rapid-fire condition comparison. Okay, time to put on our clinical detective hats for rapid-fire synthesis to lock in how we differentiate these 5 distinct conditions.
Take a look at the matrix. Notice how identifying the root cause directly dictates your very first action. For contact dermatitis caused by an external allergen like Ruscio, your action is rapid mechanical decontamination. For diaper dermatitis caused by moisture and pH changes, it's blocking the exposure with a thick barrier cream. For seborrheic dermatitis, driven by thick scalp scaling, it's gently softening those scales with petrolatum. For atopic dermatitis, driven by chronic barrier dysfunction, you're executing that strict, tepid bathing and moisturizing sequence to break the itch-scratch cycle. And finally, for exanthematous drug eruptions, caused by a systemic cell-mediated response, your very first action is identifying and withdrawing the triggering medication.
So as we wrap up this explainer, I really want to leave you with a final thought to ponder. If we start viewing a pediatric patient's skin not just as a flat surface, but as a highly vulnerable, dynamically changing shield, how is that going to change the way you approach every single bath, every application of lotion, and every clinical assessment moving forward? It kind of changes everything, doesn't it? Because protecting that barrier really is the foundation of pediatric care. Thanks for hanging out at the virtual whiteboard today, and keep exploring.